present and to add to the development and the training of our residents. So today we'll be rounding off the series of lectures on assessment and management of difficult airway. So today we'll be talking about the management of difficult or failed intubation. So our learning outcomes would be to define difficult airway and failed intubation, explain the different components of the difficult airway management, explain the importance of communication and teamwork, or generally human factors in airway management, to describe the different advanced airway management techniques that we could easily use, especially in the low and medium income countries, to discuss management of difficult airway, failed intubation using the Difficult Airway Society algorithms. The incidence of Comac and Lehen laryngoscopic grades 3 and 4 has been reported to be up to 10%, while difficult intubation is 1%. And in some of these patients, they equally have difficult bag mask ventilation, up to 5%. Since the 90s, with the creation or innovation of fiber optic bronchoscope, as a recognized standard of care by airway societies, practice guidelines for the management of difficult airway has involved this device with a success rate of 88 to 100% anticipated difficult airways. Please, can you mute yourself if you are not talking? Despite expert recommendations and the availability of video-assisted devices, it is still not a common practice in low and medium income countries, mostly due to perceived complexity and lack of skill. So guidelines and protocols, education, training are essential, especially in our environment. So who can tell me, we defined difficult airway last week. Who can tell me what difficult airway is? Anyone? Anybody can define difficult airway if you know. Can you kindly unmute yourself? I hope you can hear me clearly. Am I loud enough?
Yes, you are loud enough now, yeah.
Okay.
Yes, we can hear you.
Okay, anyone trying to attempt what is a difficult airway? We need to move quickly today. We have quite a number of slides to go through. Anyone? Okay. All right.
Difficult airway. Difficult airway is a clinical situation whereby a trained conventional anesthesiologist has experienced difficulty in face mask ventilation, intubation, or both.
Okay, very great attempt. So let me just go on. Like you said, in healthcare, who is skilled in airway, experiencing difficulty in one or more recognized techniques. So that can be face mask, tracheal intubation, or both, according to ASA. But then Canadian guidelines now involves even the consideration of the airway at extubation. So what is difficult intubation? This is a trained anesthetist using video laryngoscope taking more than 3 attempts or more than 10 minutes to complete the tracheal intubation. So the airway becomes worse with every new attempt. And it's considered in terms of anatomical or physiological reasons. Now, who can tell us what a failed airway or failed intubation is? Anyone? What's a failed airway or what's a failed intubation? Do I call people? Or are you looking through your books? Okay, Dr. Abubakar Abdullahi, can you answer us? Dr. Abubakar Abdullahi, can you attempt the question? Hello? Can you unmute yourself? Okay. So let's not waste too much time. I'll just go ahead. All right. So a failed airway is when there is a failure to perform gas exchange in a patient that cannot do so on their own. And an intubation, a failed intubation is an emergency mandating action. But you must always remember that oxygenation is the most important thing, okay? And we want to avoid the can't intubate and can't oxygenate scenario. So please, if you are not speaking, you are really disturbing us with your voice. Try and remember to mute your microphone. So this is a remember. Please, that person is really disturbing us. It's really
This is not fair. Who is doing this? Please mute yourself.
Okay, thank you. All right, so I will answer your questions at the end. So this is just in the airway mnemonics for difficult airway assessment. Okay, so we've taken all of this at our first lecture just to remind you again, and that you must also consider specific populations like pediatrics, obese, pregnant, and elderly. So also, last week or 2 weeks ago, we spoke at airway assessment and trying to bring all the information we had together. We say it's good to use the Airway Management Foundation approach, which gives us a guide to how to manage management options for assessed difficulties simultaneously through three-step approach. Number one is assessments, which we spoke about extensively. Then we went on to the assessment of the patient, then assessment of non-patient factors like resources at our disposal, equipment, and other resources, and the surgery that you want to attempt to do, what kind of airway is required for that surgery, and of course, finally, the assimilation of all assessments to divide your patient into either not being a problem at all, no difficulty, but there is possibility and impossibility, an impossible airway depending on the resources that are available to you. Under non-patient factors, you also have the mindset of the anesthesiologist or intubator. So the basic equipment and adjuncts in difficult airway, we want to particularly view them in terms of the difficult airway because we've spoken about them extensively last week. So a tip I want to give is all these airway equipments are very important in managing your difficult airway. It cannot be overemphasized. However, a particular one I want to emphasize is when we are using the bag mask ventilation, the single operator bag mask ventilation requires practice. And the two-man ventilation is more effective in difficult situations. So all this equipment are used all along the plan A, plan B, plan C, and plan D. So, of course, you know your oropharyngeal airway or nasopharyngeal airway are very important, and your stylets, whether they are the malleable or the flexible, and your bougies, especially the hollow ones that can provide you some time for oxygenation. Now, I've put in 2 videos here because we can't go with everything that you need to know on it that you can access later and see how these things are employed, especially in difficult airway scenarios. So the other adjuncts are the suction catheters. The intubating catheter entry, which is particularly important for fiber optic, that can be used either in awake or asleep patients, and the hollow bougie that I have spoken about earlier, and your tube exchanger that is particularly important at extubation. This is another video there for entry catheter and hollow bougie use. The laryngoscopes in difficult airway, as we know, there are different types, particularly the McCoy, the straight blade for pediatrics, polio, the improved vision, and then the occiput. This is a video showing how to use the McCoy, and we all know how these things come in. We've spoken about them extensively. It is important that these things you learn how to use them, even on patients who do not have difficult airway, if you have them in your centers, so that when the difficult airway comes, you have become more adept and comfortable with using them. So the supraglottic airway device, the tips that I can give you concerning this is that you should have adequate anesthesia if you are not doing an awake intubation, because there could be difficult placement due to laryngospasm, bronchospasm, and there could be resulting airway obstruction. So you might require additional anesthetic if you encounter any of these issues. Now, downfolding of the epiglottis, the tip of the epiglottis can be flipped over as the supraglottic airway device is placed. So when you heard it could be noisy, could present as noisy ventilation or total airway obstruction. So the up and down maneuver can help to unfold the epiglottis. So you withdraw the supraglottic airway device by 2 to 4 cm and reinsert without deflating the cuff. So that's a very good tip. If you find that you have an inadequate seal, so you can hear the air, the flushing sound as you ventilate through the airway tube. So it might be an inappropriate size, or it could be a difficult or impossible seal. So you want to know if you can use a larger sizes to create a better seal with lower cuff inflation volumes and pressures. So patient anatomy is always a consideration. So placement may be difficult because of anatomical features. So all of this must be well assessed before you place it. And of course, these are the videos placed there for you that you can view for the placement and the guidelines to that. For our video-assisted devices in difficult airway management, the main thing about these devices is that they offer improved visualizations. So there's a clearer view than traditional direct insertion of the supraglottic airway device for the video LMA or even for the laryngoscope, especially in difficult airways. So easier airway management comes out of that, and this visual guidance can lead to more successful and less traumatic interventions, particularly in difficult airway. So you can see the video silent there. This is particularly important, especially if you are planning to do a nasotracheal intubation. The conditions that allow for that will be discussed as we go on. So reduced cervical spine movement, these are particularly important. You don't need to do the cervical spine manipulation to get your airway in situ. So we all know that studies have shown that video laryngoscope improve first pass success. But while visualization does not always mean successful intubation, we know that there's a better overall success rate of intubation, reduction in intubation time, superior visualization of the glottis. And if you have that, you can easily use other airway adjuncts to then achieve success in intubation. There are fewer intubation failures with the video laryngoscope. there's a greater first attempt success rate with the VL. So our video laryngoscopes, you see that there are different types. It is at this point that I need to tell you that you need to get abreast of whatever one you have. Don't just be looking at it. Take it, use it in patients that do not have any difficulty. ASA, Mallampati 1 patients, get used to it, read up on it, watch the videos that have been sent with the slides. So the tips that I will give you is that as you enter the mouth, you should enter the mouth slowly and you focus on the screen, not the inside of the mouth. This is the commonest problem or that I encounter when I'm teaching my residents, because you're so used to looking inside the mouth with a direct laryngoscope. You have to teach yourself that the moment you enter and you can see the tongue, the next is to direct your view to the screen, whether it's a screen on the laryngoscope or a remote screen far above that everybody can view. So a great view, you can have a great feel, but you might be unable to direct the endotracheal tube through the cords. So you can help this by withdrawing the blade slightly. So that's another thing that a lot of residents encounter. Unlike the direct laryngoscope, with this, you need to enter slowly. Don't go all the way and then start retracting. Sometimes in doing that, you might traumatize the airway. And if you have a patient that is not well anesthetized or has anything that will cause bleeding, this might stimulate bleeding, and then there could be always soiling and all of that. So you withdraw the blade slightly, the cords come into view and should occupy the top half of the screen. So the rigid stylet is also an essential one in conduited video laryngoscopes. I will show you what I mean by that, and also hyperangulated blades. So the hyperangulated blades allow further vision around the corner, and they are useful in situations of anterior larynx. So they can result in a very steep angle approach. If you can see the first cricoid ring, then you have an approach that is too steep. So this is a picture depicting what I mean by the conduited. So you can see the a hollow space there that you can put your laryngoscope, and it's supposed to also, you can put your tube through. So you can see the tube already loaded with the rigid stylet. So this is the intubation there. I'm using a mannequin. So as you are going through, you can see that your rigid stylet is hockey stick shape and it's curved already. So you put it within that channel there, the channeled video laryngoscope, and you go through. So if you put it separate from it, you might miss the laryngeal inlet. So if you do it properly, it just slips directly into the larynx without you having to do much manipulation. When you are going to then remove it, you don't remove it like you remove your malleable and move it straight. You need to bend the tube while you hold the tube with the video laryngoscope together, and you remove it according to the anatomy of the stylet, the rigid stylet, to caudally and not straight. So these are some videos that will also further explain how to use the VL and how to remove that rigid stylet safely. So for the flexible bronchoscope, the main clinical uses are in improving our visualization, just like every other video assisted device. But it's particularly useful in awake tracheal intubation and in all other combination techniques. This video clearly shows a step-to-step guide for the use of flexible bronchoscope. Now, what are the tips that are important? Warming the tube. So your tube is supposed to be loaded first on your fiber optic bronchoscope, but before you load it, it's good to warm it in a basin of saline. This improves its flexibility. You can apply a bite protector. There are bite plugs that are available, and this is particularly important in orotracheal intubation. These bite plugs would not disturb your the introduction of your fiber optic bronchoscope and prevent the patient biting on it and destroying it. So the fiber optic bronchoscope should be lubricated with normal saline or distilled water, not lidocaine spray or gels, as this can occlude your visualization. Then the appropriate size should always be chosen for the appropriate tube. It might be important to consider using a longer tip to increase maneuverability. Then streamlining the ET tube, like I said, fixing it maybe with some tape to the fiber optic bronchoscope till you achieve direct visualization within the airway. Then you can untape it and then introduce it as described in the videos. So the resistance at the epiglottics or arytenoid usually can occur. So you might need to draw it back the endotracheal tube by 1 to 3 cm, rotate it counterclockwise or what we call anti-clockwise by 45 to 90 degrees, and then reintroduce it gently. So this is a diagram just depicting everything I have said, putting all those things that are important. We'll talk about positioning later, but these are the equipment and how you can use them. The number of attempts that are allowed is like a pictorial depiction of the DAS algorithm. So you see the devices that you use in plan A, the devices that are required in plan B, the devices that can be used in plan C, and the devices in plan D. We all know that plan A is initial intubation strategy, plan B is supraglottic airway device, and then plan C is maintaining oxygenation and ventilation using any of these devices as well. And then plan D is where you can't intubate, can't ventilate using all the front of neck access devices, depending on what your skill is. Now, the question I want to ask anybody, how would you manage this airway? Anybody? Can anybody attempt? No attempt is wrong. So just, you can put it into the chat box. What do you think about this airway and how would you approach it? Just tell me, what would you do? What first comes to your mind? Okay. Okay, somebody said awake fiber optic intubation, good. Video laryngoscope, good. Awake fiber optic, I think awake fiber optic. Oh, somebody said tracheostomy. Okay. Aha. So how would you achieve tracheostomy in this patient? I think all of us agree that that would be a Herculean task. So I think everybody has said awake fiber optic intubation. That's a very good answer. And this can be done in different ways. As we go along, we will see that. Okay, so when you approach a difficult airway, there are questions that you need to ask yourself and your team. So the Entray 6-step approach has been given to us for the difficult airway management, and it's also recommended by the ASA, it's recommended by the DAS, and they say you ask yourself, how much time do I have? In other words, is it an elective or is it an emergency? If it's an emergency, do I have time to optimize this patient? Number 2 question, what access to the airway is available? For that kind of patient, do you think the trachea is available? Obviously, that patient we're seeing is possibly an elective case because we've not been told there's any airway obstruction, and it doesn't look like that. So is the nose, if the airway or the mouth, the trachea is not available, is the nose or mouth available? So for that person saying tracheostomy, you can see that it's unlikely that that neck will be available for you to do a tracheostomy. So how compromised is the airway? For that kind of patient, you want to assess, is there any obstruction in this patient? Any signs of obstruction in that particular patient? The history might be pointing to that, and even physical examination. So which facial spaces are involved? So you want to know, is it the oropharynx or the nasopharynx? And then is the posterior facial involved, and all of that? You want to know what spatial spaces are involved. Then which management plans best fits the circumstances? Now, when you are considering this, like we go back to the AMF Foundation, a patient that might be I might be able to intubate in the OR. Am I able to intubate that patient in the A&E? That's just a simple way to look at it. Or in your institution, do you have all the equipment? Everybody now has said awake fiber optic intubation. How many of you have done it before? How many of you have all the requirements for it? So this is why when you're looking at the airway, all these things have to be brought together for you to take a decision. A difficult airway for you might not be an impossible airway for you in your institution, according to your skills or according to the resources you have, might not be for somebody else who has all that at their disposal. And always, one thing that a lot of us don't think about is, how could I make the situation worse? This would come from answering this question. So if so, how can I? For example, if you don't have all you have, or you don't have the skills, or you don't have the assistance, or you're tired, you don't want to go ahead with that thing because you might make the situation worse. So there are different categories of difficult airway scenarios, or different airway scenarios. Like I said, the first question is, do I have time? Is it an elective? As you can see in this guy, he's living his life without you doing anything to his airway. Or is it an emergency? Like in this lady, totally distorted anatomy. So the problem we usually, for here, you already know it's anticipated. When it's anticipated, there's a degree of time that you can use, because then you already know that I'm going to have a difficulty, and you have the mindset to prepare at least. Whether it's an elective where you have more time to prepare, call more people, or emergency where you have little time, but at least you know what you are up against. Unlike in an unanticipated difficult airway, you know, this person is coming, probably has passed this road a number of times. Just imagine he got into this probably because he passed that road yesterday, he didn't have any problem, and he's done so many patients, and suddenly he just goes to the OR, and then the patient sleeps, he puts his laryngoscope, and he can't view the larynx, or he can't insert his endotracheal tube for various reasons. So this is a nightmare for a lot of us, because it is totally unanticipated. And it occurs many times because there isn't adequate assessment of the airway. So the management of difficult airway has different components, and these include a detailed airway assessment, like we have said. So today we're going to be going through preparation and planning, optimization of the patient and the situation, communication and team dynamics, airway algorithms, and our plan for extubation. So the components can also be remembered by 4 Ps. The first P is prepare your patient. Is pre-oxygenation optimal? Then the end tidal oxygen should be greater than 90%. The difference between this, the end tidal oxygen is the concentration, oxygen concentration in the alveolar space at the end of exhalation. It's non-invasive, and it can be done by some special capnograph. You want to consider, is there CPAP? Do this patient need CPAP? Would it improve the patients? You want to use that and the other gadgets that we can use for pre-oxygenation. Is the patient's position optimal? You may need to consider head up. Can this patient's condition be optimized any further before intubation? How will anesthesia be maintained in this patient? Then you prepare your equipment. I think not just the airway equipment, but also the monitoring equipment. And of course, all the other things you will need. Then do you have all the drugs required? Considering the condition of the patient, this would determine the types of drugs that you will use. Like I said, think of this component we are discussing mainly in terms of the anticipated difficult airway, okay? When you have, or like I always say, if you practice this in every patient, it becomes part of you. So if you have an anticipated or difficult airway, it is easy for you to prepare all this, but get into the attitude of doing it for every single patient so it becomes routine. Then you prepare the team, you allocate roles. What everybody is going to do is allocated. How do you contact further help if it's required? Then preparing for difficulty. If the airway is difficult, I cannot intubate or pass an LMA. Could I wake up the patient? You must always consider this. Then what is the plan for difficulty? There's a slight mistake here because the plan B is the LMA, second generation LMA, and the plan C is bag mask ventilation. Then the plan D is front of neck. Where is the relevant equipment? So this is why we spoke about the difficult airway cart or trolley last week. Do not start till everything you need is available. There is no hurry. Whether it's elective or emergency, it's important that you have a difficult airway trolley, which is always there, checked every day, like we said last week, so you are not looking for everything all around. Do we anticipate some specific complications? Now, this is also a slight modification that is used in critically ill patients, and it takes into consideration the fact that the physiological difficulty that might be encountered, and to actually ask those questions to modify, to optimize the patient before the patient is taking, any attempt is made at intubating or managing the airway of the patient. Okay, so another thing I want to note here is noting the time. There must be somebody taking the time because it's so easy to lose track of time. And you know, time is of essence in airway management. So the next thing is going into in-depth of preparation and planning. So under the preparation and planning, like we've said, you've assessed the patient anatomically, physiologically, your resources, and your skills. Then clinician, confidence, know your limitations. Am I tired? Am I stressed out? Call for help, and proper airway assessment is dependent on the clinician. Situation awareness. Where are we? Are we in a place where we can get everything we need? Do I have assistants that will manage, that would help me adequately? Is there too much noise? Do I need to move this patient elsewhere? I've had many situations where they called us for airway management in the wards or the A&E, and I felt we would not be able to do it well there. So we moved the patients to theater because that was a better place to control our environment. Then the equipment and drugs, which one do I have? Where is it? Are you familiar with it? Are your equipment working? Then the team preparation, you need to discuss these things. What do we know? What do we expect? What do we do first? What do we have? All these things should not be assumed. Everybody should be briefed on it, and roles should be adequately assigned. There must always be a backup plan. So this is why we have that airway checklist that I discussed just before the slide. Remember always to plan, because when you don't plan, when you fail to plan, you plan to fail. So pre-oxygenation. Intubation of critically ill patients is a high-risk procedure with high rates of complications, including hypoxemia, hypotension, and even cardiac arrest, and it can happen very quickly. So we can pre-oxygenate. It is important that you try to pre-oxygenate at all times before intubation. And like we know, there's unanticipated difficult intubation. So it is good to pre-oxygenate. And you can do it with face mask, if it's applicable, a nasal cannula, a nasopharyngeal catheter, an adapted endotracheal tube, a supraglottic airway device, yes, a rigid bronchoscope, if you are going to use that, tracheal tube, or the front of neck catheter. So oxygen insufflation can also occur through channels located in all those devices, like some of our laryngoscopes, direct laryngoscopes, or through some video laryngoscopes, or through a high-flow nasal catheter or Thrive device. So this high-flow nasal catheter device, nasal cannula device, has the advantage compared to alternative methods such as bag mask ventilation and the non-invasive positive pressure ventilation. It may be as effective as the NIPPV and superior to the standard oxygen therapy for pre-oxygenation prior to intubation in especially critically ill patients. So apneic oxygenation during airway management can also be achieved using that device, and it can stay on the patient and provide continuous oxygen therapy, possibly providing positive pressure even during apneic periods compared to the bag mask or the MIPPV. So Livingston is one of the fathers of telling us of airway management and even oxygenation, and he coined an acronym, NODESAT, which is nasal oxygen during efforts at securing a tube, to describe apneic oxygenation using unwarmed dry oxygen via standard nasal cannula at 15 liters per minute to extend the safe apnea period. Patel et al. Later derived another acronym, called Thrive, transnasal humidified rapid insufflation ventilation exchange, to describe apneic oxygenation via heated humidified high-flow nasal cannula. And this is important because the heating and humidification improves the airway of the function through enhanced gas flow, pulmonary compliance, rather than using cold and dry gases. So this is the nasal cannula. You can leave it there, but you know that when you're going to put your face mask, this might impair the seal of the face mask. So that's one disadvantage. But the flow rates can be from 1 to 6 liters per minute. Then the high flow nasal cannula allows oxygen to be delivered at higher rates, sometimes up to 60 liters per minute. And you can also calculate for COPD patients, you can titrate the percentage of oxygen. You can see it there. Some of their cannulae are now soft enough to allow for oxygenation. They are softer to allow for continuous oxygenation even while you are using the face mask, or sorry, even while you are intubating the patient, or if you need to pass through the nose through a fiber optic bronchoscope. So this is showing the modified or preformed endotracheal tubes that you can put in situ. I put this there particularly because many of us might not have this device in our institution. So you can see there before they start bag mask ventilation or face mask ventilation, pre-oxygenation, the Thrive, the high flow nasal catheter is on top of the forehead of the patient. The moment they are done with this, then they now apply this, because you can see here the patient is already under, so there's apnea. This is when the patient is breathing spontaneously. Then when the patient is apneic, they apply the high flow nasal catheter and continue with their attempts at intubation. So another thing that we don't usually talk about is carbon dioxide clearance. The elimination of carbon dioxide from the body is limited during apneic oxygenation, such that hypercarbia and acidemia may ensue over time. So the degree of carbon dioxide accumulation that occurs during the blood and is greater in the first 1 minute compared to the other minutes. So some of this, the clearance of this carbon dioxide, depending on the flow rate, can be administered, flow rate of administered gases and the proximity to the administration to the alveoli in animal studies. However, it has not really been shown in adults, like human subjects. So, but it's still theoretically possible that higher flow rates are believed to extend the region of turbulent gas flow. And so the high flow nasal oxygen has been shown that to attenuate the rise of the carbon dioxide, reduces it to 0.21 to 0.24. And this has been proven in 2 case series that have been carried out. So let's go straight to positioning. So an infant in sniffing position, you can see, you can do it with either a headrest or a shoulder roll, or you can just do it with sorry about that, with a simple head extension. So what you want to achieve is 3 things. The glabella and chin must be horizontally aligned, as you can see there, number 1. Then number 2, the neck should be wide open. And number 3, the external auditory meatus must be in line, horizontally aligned with the suprasternal notch. And you can do it either by simple head extension or using the headrest and shoulder roll. Positioning in obese patients and pregnant patients, you can see that what we want to align at all times is the 3 axes, as should be assuming sniffing position. So the atlanto-occipital, the temporomandibular, and the C-spine should be aligned. So especially in difficult intubation situations, and you can use ramping or head elevation to achieve this. And of course, here also you have the air to sternal notch. So the bed angle is also one thing that has not been extensively researched. However, you note that the optimal bed height and angle is based on other factors like patient's body size and the intubator's experience. But it's universally accepted that the height of the bed should be at the umbilicus of the provider and combined with a bed angle of 25 to 45 degrees to improve the glottic view and facilitate intubation. Another thing that is not usually spoken about is airway decontamination. So some researchers have come up with this to counter that the salad method, which is suction-assisted laryngoscopy airway decontamination, using the rigid suction, not the flexible one. So most algorithms are centered on ventilation. This is a video showing how that can be done, describing it extensively. So why do we need it? Fleas and enemies of all airway management, whether you're doing a back mask ventilation, supraglottic airway, pre-oxygenation, or endoscopy. There are major determinants of failure of fast-pass intubation attempts, and many studies have shown that. The top 2 causes of failure in videolaryngoscopy are soiling or blood, the soiling, bleeding, and airway edema. So it's very important that you practice this salad, especially in patients at risk. And like I say again, and I emphasize here, get used to doing it in normal patients. So the benefits, it helps visualization on entry and throughout the airway management process. It aids alignment and insertion of the laryngoscope in grossly contaminated airway. So bringing all of this together, we'll go through the algorithm. So we have unanticipated difficult airway now. When you encounter, you have tried to intubate, you did not know it was going to be difficult. What do? So the first plan is face mask ventilation. You started with your face mask and you attempt at intubation. So what do? You optimize head and neck position, you pre-oxygenate, you ensure adequate neuromuscular blockade, direct or video laryngoscopy, it is advocated that we all practice video laryngoscopy as the first attempt in all patients now. Okay, so your maximum attempt is 3. That's the first intubator, and 1 attempt by the second intubator. If there's problem, you want to do something different from the second time you're attempting. External laryngeal manipulation using your bougie if your Comac and Lyon view is not adequate, and then maintaining oxygenation and anesthesia. So if you have any difficulty with any of this from that time you start having your first failed intubation, you ask for help. So if you succeed, go on and do your intubation and confirm with capnography. However, if you fail, you declare immediately failed intubation within theater. So the second generation is what you use first, and you also have 3 attempts, a maximum of 3 attempts, and then you try to oxygenate and ventilate. If you succeed, you then stop and think, is this airway adequate, or do I need to wake up the patient? Can I intubate the trachea via the supraglottic airway device? Do I proceed without intubating the trachea? Do I need to leave this airway, supraglottic airway there, and do a tracheostomy or a cricothyroidotomy? So if you do not succeed, you need to declare supraglottic airway ventilation failed, because your main aim here is to maintain oxygenation, is not intubation. So if you declare that, everybody knows, and you speak it out loud, so everybody knows the implication of that in theater. So you now attempt finally your face mask ventilation. Is it possible? If it's impossible, do you want to paralyze further, or you want to use, like I said, the 2-person technique and other adjuncts? So if you succeed, please wake up the patient. That's not a time to be playing or to be faffing around, because there could also be airway edema, airway soilage, bleeding, and all of that. But if you don't succeed, then you go to scalpel cricothyroidotomy. So after all of this, if you succeed at this point, hopefully, then you need to formulate immediate airway management plan. You monitor for complications, you complete airway alert form, and you explain to the patient in person and in writing, and ensure that they know what is happening. Okay, so this is just a repetition of everything I've said before. Okay, so let's go straight to awake tracheal intubation. Now, you have an anticipated, if you have unanticipated, we've discussed what to do. But if you have an anticipated difficult airway, the options are all the things that we are going to be discussing. So you are not unprepared. You know you are going to have difficulty. So the amount of difficulty will dictate whatever method you want to use and how you've assessed difficulty along all the airway plans. So for patients that have very severe difficulty, from your assessment, awake tracheal intubation is one of those things that you should consider. So awake tracheal intubation is placing an endotracheal tube in a spontaneously breathing, awake or likely to moderately sedated patient. It was first described by Sir William McEwen, a Scottish surgeon, in 1880, of a patient suffering from obstruction of a tumor from the base of the tongue. It's valid and highly recommended for predicted significantly difficult airway management or those who may not tolerate the apneic phase following neuromuscular blockade. So your approach can be visualization device. You can use a visualization device like the fiber optic or the video laryngoscope. So I tell people that it's not only the fiber optic that can be used for awake tracheal intubation. So any patient, any device you can use in a sedated or patient who is sleeping can also be used in awake tracheal intubation. All you need to do is anesthetize the airway adequately. So the routes, your visualization device can be fiber optic, it can be VL, it can even be a video LMA. You can use the route, the oral route or the nasal route. And Your choice is dependent on your assessment of your patient and the skills that you have. So options include video laryngoscopy, supraglottic airway, combination techniques, and all require topical anesthesia plus or minus sedation. Most people they are advocates for light sedation and they are advocates for no sedation at all. Everything depends on how you've been trained and the condition of the patient. So direct laryngoscopy and optical stylets too can be used. There is no evidence of significant differences in time and success rates. Therefore, it can also be used and considered as valuable alternatives. So for us in low and medium income countries, we really do not have an excuse. We need to learn this skill. So selecting the patient for awake tracheal intubation is actually the most difficult part. So what are the contraindications? Patient refusal, uncooperative, unresponsive patients, non-responsive patients, patients with altered mental status, airway trauma, local anesthetic allergy. The benefits are they avoid hypoxemia and hypercapnia, reduction in the risk of aspiration because the airway protective reflexes are preserved, avoidance of the risk associated with induction agents like hypotension, bradycardia, hemodynamic instability, and increased morbidity and mortality. Some people are afraid of doing this in very critically ill patients, but studies have shown that it's actually beneficial in this set of patients, particularly for those reasons. So there are 6 questions for awake tracheal intubation to be answered. Is this airway challenging enough to require a tracheostomy under local anesthesia instead? If not, a supraglottic airway is not ideal, and awake tracheal intubation may be desirable. And is the nasal or oral route required according to surgical or procedural preference? Will a needle-based local anesthetic block be instituted, or a topical airway be the sole anesthetic, stole technique? Will an antisyllagogue agent be required? Which sedation techniques will be required, if any? Lastly, which method of tracheal intubation will I use? Is it direct? Is it flexible? Or is it video laryngoscopy? And this is a video of tracheal intubation and airway anesthesia, awake tracheal intubation and airway anesthesia. So there's a DAS ATI technique like an algorithm. It's called small STOP, stop. So the small s is because sometimes sedation might not be required. It's not mandatory. And you can use, so you start from the S here. You can use remifentanil target control infusion at that dose, or you might require more midazolam, especially if you have another anesthetist, and also assessing the patient if they can tolerate any sedation at all. So topicalize. Remember, the reason why you are doing awake is because you don't want the airway compromised and the patient sedated. So you can topicalize with lidocaine, and more information on this in the videos because we are running out of time. So you almost always remember to oxygenate and continue to do using the hyphonasal cannula or otherwise the other techniques available to you. So you want to select appropriate tracheal tube, patient sitting up, ensure operator can readily see the patient monitor, infusion pumps and video screen, then you clear secretions. So for awake tracheal intubation, you want to use a fiber optic bronchoscope. Then if you are doing that, the operator should be positioned facing the patient, consider bronchoscope airway if oral route, and then bevel facing posteriorly. If you are using a VL, the operator position behind the patient, and you should consider a bougie. Then after you've done your the induction of anesthesia, you want to do the 2-point check. The 2-point check is when you ensure that you saw your tube go in using your video assisted device
Hello, Dr. Adesiyan, we can't hear you.
Or you also check with back to the second anesthetist will be here waiting, looking, but also has a view of the video monitor, seeing what is going on. The video monitor is here because the operator is here. Then patient monitor is here. Okay, so the airway trolley too is available. So there are some complications that can arise, and you want to review your sedation in case the patient is too sedated, and depending on the view you see, do you want to consider reversal agents if they are too sedated? Additional topicalization might be required as you introduce your video assisted devices, but make sure you look out for local anesthetic toxicity and how to manage it. Clear obstruction, reduce or reverse sedation if possible. You increase the FiO2 or you change your mode of O2 delivery in terms of oxygenation. Then for the performance, limit your attempts to 3+1. That means the first 3 will be by the first intubator and 1 by the second intubator. You must also consider if you need to abandon the procedure, suction, and alternative routes, and maybe you should change the tracheal type or call for more experienced help. So there can be unsuccessful awake tracheal intubation. So what do? First thing is you call for help and you administer 100% oxygen. You stop every sedation. So when you do that, you now stop and think, is this immediate airway management essential? If it's not, please postpone the procedure and call for more expert help. If it's yes, you need to go on, then you need to do a FONA. Is this FONA appropriate using awake FONA? In other words, awake tracheal intubation using the front of neck access. If it's appropriate, you can go ahead and do it. If it's not, then this is a high-risk GA that you want to attempt. And if it's failed, if you tried it and it failed, then it's also a high risk. So a further explanation is given to the different steps there. So the final topic I want to discuss is retrograde intubation, also called translaryngeal guided intubation. This is particularly an option for us in limited resource environments because it is an anticipated difficult airway and we don't have fiber optic intubation, bronchoscope, or you don't have a VL, or you're not trained in those techniques. You can also learn this as an alternative. So especially for patients going for maxillofacial anatomical deformities, it is used after adequate preparation of the patient, of the equipment, and planning improves the rate of success and reduces the incidence of complications. So airway anesthesia with or without sedation also can be used in this patient. Remember, the patient is awake. So patient education is important to ensure patient cooperation and reduction in the risk of airway trauma. So it can be oral or nasotracheal as well. And you can use it with fiber optic or direct laryngoscope to improve the chances of success. So the classical, the guide wire and seat proof are the 3 techniques used for retrograde intubation. So what are the indications? Failed laryngoscopy, LMA, or fiber optic intubation. Any difficult intubation where cricothyroid membrane can still be located, urgent establishment of an airway, and elective limited mark opening less than 2, unstable spine, oral maxillofacial surgery, trauma, or congenital anomalies is particularly suitable for facial trauma, where nasal intubation is contraindicated. So the contraindications are unfavorable anatomy, lack of access to cricothyroid membrane, severe flexion, deformity of the neck, poor anatomic landmarks like obesity, pretracheal mass like thyroid goiter, laryngotracheal disease, malignancy or stenosis, coagulopathy, and infection or lack of skill. So the classical technique is performed percutaneously using a 70 gauge Tohi needle and epidural catheter, as you see in the diagram. For the guide wire, it's a modified classical using a guide wire is developed because the flexible epidural catheter can experience kinking. So the equipment are the 18-gauge angio catheter, a G-tip guide wire, and a guide catheter. This guide wire technique is less traumatic, is easier and faster. So for the silk technique, it's the classical technique is performed first, and then the epidural catheter there is attached to a length of silk, and the catheter silk combination to the endotracheal tube to pull it into the trachea. So this is a good video that helps you to understand the classical technique. So the last, well, let me say the last is the three main techniques for the emergency phona or surgical airway. So the scalpel cricothyroidotomy, this is a good video for it that I have described over and over again. Some people still use the needle and cannula, whether narrow or wide bore, have been seen to have less success rates compared to the scalpel bougie and the tube technique that we've described. And of course, we always remember, if it's elective, you can do surgical tracheostomy. So the aim is to just put a patent airway via the anterior neck to facilitate emergency alveolar oxygenation. Okay, so you can use, these are videos showing how to localize, because for the retrograde intubation and the front of neck access or surgical emergency airway, the main step is locating your cricothyroid membrane. So these are videos showing all that and how we can do it, either by palpating, this is poor in female and the obese, or using the laryngeal handshake technique, or the gold standard, which is ultrasonography. And like we said 2 weeks ago, that the transverse method is better. So this is a diagram just showing how you can palpate, do the laryngeal handshake to identify your cricothyroid membrane. So I always advocate that you check it on yourself, and you check it in make it a habit to check it in every single patient, and to at least have your equipment needed for bougie-assisted cricothyrotomy, which is possibly and mostly in every theater. I think every theater has a bougie. Everyone has a 6 millimeter endotracheal tube, and the blade, size 10 blade. So have this within your difficult airway trolley. So like I said, also, I think I've said this before, you should always have a plan for extubation. So on this plan also, we have 4 Ps. Your plan for extubation includes step 1, assessing the airway and general risk factors. So is this patient at risk at extubation? Can they oxygenate? Intubation, how would it be easy? Is it potentially difficult or not? Then preparation for extubation, optimize your patient, and other factors. Patient factors are physiological. The other factors are where you want to extubate. Do you have skilled assistant? Is there monitoring and equipment? So do not rush. There is no rush about extubation. So the key question is it safe to remove the tube? If it is, you can do it awake, or you can use the advanced techniques. So in performing that, we can use the laryngeal mask exchange, remifentanil technique by instituting remifentanil to cause a bit of airway, a better condition within the airway, and also sedate your patients lightly, and it is short acting. Or you can use the airway exchange catheter, like I said. It's a very good, and patients tolerate it better. If it's not, you need to give the patient some time to awake or optimize their patient factors and get them to better other factors that you can optimize. Then you can consider a tracheostomy while the tube is still in place. Then post-intubation care. You need to consider, can I manage this patient in the recovery or PACU? Do I need to get them to an HDU where there are facilities to monitor better and possibly give oxygenation and ventilatory assistance, or do we take them to the ICU for safer management? And of course, all the other things we should consider that are part of the management of the patient. So I would finish in another 5 minutes, so bear with me. The first question here, sorry, I've shown you all my answers. Which statement best reflects an effective communication strategy during intubation? Anyone? I hope you've not seen the answer. Who can answer? Is it, can someone get the tube ready? I need a size 7.5 ET tube now. Sarah, please prepare it. Let's hope this goes well. Grab whatever is available. Which statement is effective communication? Anybody?
I think it's B.
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 Okay.
B. Yes, ma'am.
Excellent. Excellent. It's B. So it's B because it's a direct statement, it's specific, and it assigns a task to a named individual. So this improves accountability and reduces confusion. So we all make this mistake in theater. You just say, get me this, but you don't direct it to anybody. So that's not an effective communication. And always, there's another aspect that we will be discussing as we go. Apart from giving the instruction, there's also another aspect to it. Okay. So during an airway emergency, what is the most appropriate way to confirm that a critical instruction has been understood? Anyone?
C.
Closed loop communication.
Closed loop
C.
communication.
Closed loop communication. C.
Okay, so I can see we are all wonderful airway managers. So closed loop communication is a safety practice where the receiver repeats the message back to the sender to confirm understanding. And this is very vital during emergencies to ensure, this is the other aspect I was coming. So it's not good enough to give Sarah the message, but Sarah has to reply. Did you tell me I am bringing a 7.5 ET tube now? Then the person, you will know the person got the message. I've seen situations on my own practice where I thought I said something, but I said the opposite. So, for example, maybe I want an endotracheal and I say, bring me a suction catheter because maybe I was suctioning at that time. Those kind of things happen, especially in emergency situations or difficult airway situations. So repeating makes us all within the room to understand ourselves better. So what are human factors in difficult airway management? So addressing them is crucial to improve patient safety in difficult airway scenarios. It's been found out that teamwork and communication, which is what I'm going to really be hammering on, that poor communication and lack of teamwork has been identified as contributing factors up to 40% of difficult airway cases. You know, a lot of discussion goes on the type of equipment, your skills, but these soft skills of human factors and communication and teamwork actually also contribute to a lot of difficult airway cases. So leadership and followership, what do we mean? A leader is essential for directing the team. The team leader is probably the most experienced, but it's not always the situation. So, but it's essential that we have somebody directing who has told everybody what the plan is and has discussed all the aspects like we discussed earlier. So ensuring a coordinated approach to airway management is important, but the leader must also have good followership. So this involves effectively implementing the leader's directives and contributing to the overall team effort. So we don't say, you can see a leader that probably is doing something wrong. We should all be able to not be fixated and say, oh, it's the leader, or there's nothing we can do, especially if the person is a consultant. You should be able to know how to say, ma or sir, can we do this? Do you think? Or all that without disturbing them too much and helping the team and this management to be better coordinated. So situational awareness, being aware of the patient's condition and the potential for complications and your available resources helps the team to anticipate challenges and adapt their approach accordingly. Decision-making under stress. This is another place where people have a lot of problems. So the ability to make sound decisions, even in that stressful environment, and not shouting, oh, I'm dead, or the patient, I can't do it. And then you just lose all composure. That is not needed at that point. Okay, you need to not have cognitive biases, thinking about too many things, and this is why the algorithms should be placed in theater. You do not get fixated on errors. You should, because being fixated would hinder your effective decision making. So non-technical skills, being able to manage stress, coping with fatigue, maintaining composure under pressure are essential. Okay, addressing cognitive errors. We are saying this again, do not be fixated on the errors. Where clinicians become overtly focused. For example, some people just want to intubate by all means. And I tell them that not all patients can be intubated. You must always remember that what is essential is that this patient is alive and doesn't have terrible complications resulting for airway management techniques. So finally, it's very important to train yourself. Your training is force dependent on you, not your trainer. So your trainer can do as much, but you must know that sometimes your trainer too might have some areas where they are not so good. So you need to continually improve yourself and seek to get more training, not just for yourself, for your team, because your team is your support, and improve also on communication. So communication, like we said, the closed loop, we've discussed what that is. I also want to talk
Dr.
about
Adesiyan, we are behind time. 10 minutes
Okay.
after. I sent you a notification before. Sorry.
Okay, no problem. So these are just the things we discussed earlier. So I think everything is over. And then the vortex approach is about teamwork. And it's you can look at that video. It directly targets human factors and it helps us to understand how they play out in emergency situations. So in conclusion, if in difficulty, call for help. Time is crucial. Innovation and technology are only useful in skilled hands and do not replace basic clinical skills. Tracheal intubation can not always be achieved. Prioritize oxygenation with SALAD. Remember, waking up the patient can be the best option. Do not hesitate to do that. All equipment can be used asleep and can be used in awake patients. Confirm at all times using capnography. If you have POCUS, use it. Patients do not die from failure to intubate, they die from failure from trying to intubate. Thank you very much. And please be invited to our workshop and the conference where you can learn more about all these things we've discussed. Thank you. Sorry for overshooting the time as usual. Thank you. Any more questions? Prof, I'm done.
All right. Thank you very much, Dr. Adesiyan. I want to appreciate you for this past 3 weeks where we've dealt extensively with airway management. Do we have any questions, any comments before we close? We are 13 minutes behind time. Any questions, any comments? Okay, if there are no questions.
Yes, I have a question, sir.
Okay, increase your volume. Let's ask.
Okay. Good evening, Prof, and good evening, everyone. Thank you for the wonderful presentation. Please, I just have a simple question. Can we pre-oxygenate with intranasal cannula? If no, why? Thank you.
So, like I said, you can't pre-oxygenate with intranasal cannula. Remember, many things that we put through the nose. Why is it good? Because it triggers the airway less. It's more tolerated in awake patients. So that is why we can use the nasopharyngeal catheters or cannula. Okay? Thank you. Somebody asked there, what is the role of inhalational induction? Yes, so inhalational induction traditionally has been, those days we used to be told if you have a difficult airway, use inhalational induction. Now, I wouldn't tell you that it's totally absolved or you can't use it, but remember that if you have an anticipated difficult airway, what you want to avoid in the patient is sedation. You don't want the patient to lose their airway, okay? You don't want them to be sedated in the way that they cannot control their airway. And inhalational induction, you cannot intubate until you get to the level where the laryngeal reflexes are totally obtunded. I hope you understand what I'm saying. For you to be able to intubate, you want to get to that place where they are deep enough, like we used to say, to intubate. So I would not advocate it in confirmed difficult airway that you know if this patient sleeps, I might lose the airway and I will run into trouble. This is why we have all these other techniques that you can use if you already know there is a difficult airway. Thank you.
Good evening, Ma. Please, I have a
Yes.
question. Thank you very
Okay.
much for your lecture. Please, I request if you could shed more light on when you said that there is the possibility of hypercarbia during pre-oxygenation, because I believe from what was said, pre-oxygenation is removing or replacing with oxygen all the nitrogen and every other contents of air. So there's mainly oxygen there. So how does it occur? How does hypercarbia occur in such a state where it's mainly oxygen that is in the system? Thank you.
Okay. Thank you very much for your question. So what I did say was apneic oxygenation. Now you have to understand that when those patients, mostly in very critically ill patients, when you are oxygenating, it's and they are apneic, there is no effort to sort of bring out, when you into your gaseous exchange in an awake, spontaneously breathing patient, they inhale the oxygen, they exhale the carbon dioxide. But in patients that you are doing apneic oxygenation, there is no effort whatsoever. So you are oxygenating very well, yes, because you are forcing in under what would I call it now? You are putting in that oxygen under a lot of pressure from your whatever device you are doing, you are using. However, what brings out the carbon dioxide? There is no effort, there's no breathing out. So you can accumulate that. But if you use a very high flow, then it can dilute it. And like they said, they've been able to prove in animal studies that it improved the exhalation or the removal of carbon dioxide. Okay, so there is accumulation because there is no breathing. It's not your normal oxygenation of a spontaneously breathing patient. I hope I've cleared your views. So
Thank you very much, ma'am. I'm very grateful.
All right. Okay. Do we still have any other questions? Okay.
Okay. I think our time is past, man. Thank you, Dr. Adesiyan. Thank you, everybody.
Thank you very much, Prof. Thank you for the opportunity. Thank you, everybody, for listening to me for these 3 weeks.
All right. Thank you. Please do have a wonderful evening, and I'll see you again next week by God's grace. Bye.
Yes. Bye, everybody. Bye.